Dr. Rodolfo Savica is a professor of neurology, a practicing neurologist, and a movement disorder and behavior specialist at the Mayo Clinic in Rochester, Minnesota. Along with being a medical doctor, he holds a Ph.D. in neuropsychopharmacology as well. Dr. Savica has a particular interest in early onset Parkinson's, and he is leading the initiatives of the Mayo Clinic in Rochester regarding the clinical practice and research on early onset Parkinson's. He's also involved in an array of efforts for patient education and scientific advancements. His leadership includes serving as the chair of the International Movement Disorder Society Task Force on early onset Parkinson's, and he leads a lab as well with the goals of finding a cure and improving quality of life for people living with PD. When he's not treating patients or conducting research, Dr. Savica likes to spend time with his amazing wife and their lovely daughter, and he's also a well-established martial artist. It's my pleasure to welcome to PD Wise, Dr. Rodolfo Savica. Dr. Savica, welcome to PD Wise. It's a pleasure to speak with you today.
Thanks for inviting me. It's really a pleasure to join you and to have the opportunity to talk to you.
Thank you. Well, let's start with this question. What is Parkinson's disease?
Well, classically, Parkinson's disease is being considered a condition that is degenerative, so is a progressive condition affecting the neurons of the brains, especially a group of neurons that are located deep inside the more deep structure of the brain called the basal ganglia. When there is a damage and an early death of some of these neurons that are usually responsible, that are considered to be responsible for movements. And typically we were taught that in order to see this condition occurring, you had to lose 70% of your neurons in this area in order to see the symptoms. Realistically, was based upon some old pathological studies that are still very valid, but we know now that Parkinson's disease does not only affect the group of cells deep inside the basal ganglia, affects the entire cortex, affects the entire nervous system. And is not only and it's important to say because the symptoms of Parkinson's disease initially were thought to be only tremor, quote, quote, tremor, rigidity, falls, being very slow, because the major amount of attention was brought to movements and the motor symptoms. But we know now that there's an entire array of different symptoms that are not necessarily coming from the motor system, but has some connection with the motor system, that are more important, is not as important compared to the motor system, motor symptom. I'll give you an example that is, I think, quite relevant. Typically, the normal general concept on Parkinson's disease is that, okay, I have this gentleman or gentle lady in their 80s and 90s that start to shake whenever they're in public. Well, that is not exactly what we see. Shakiness is one of the symptoms, is not the symptom, is the most recognizable symptom. But we know the basal ganglia and the structure deep inside the brain that are affected by this process are responsible for memory loss, for planning, for finding and executing the right plan during our life and during our entire lifetime, not just a motor planning, but all sorts of planning. Something that is not easily recognizable with a naked eye, but something that usually can be a major symptom in Parkinson's disease.
Yeah. Yes, it's a very complex disease that we're learning a lot more about thanks to your research, which I want to talk about here too. But first, how did you get interested in researching and treating Parkinson's? What was your path to where you are today?
So when I was a medical, so I went to medical school with the idea of becoming a psychiatrist. that hence my interest still in the higher cortical function of the brain. But I remember as if it was yesterday, at my second year of medical school, well, maybe it was my first, but anyway, I remember the first lesson on anatomy and physiology of the basal ganglia. And as I say sometimes ago as well, it was love at first sight. I was struck by this particular structure, and ever since the time, long ago, unfortunately, I never stopped studying them and getting deeper in the knowledge of these little structures that are fundamental for our life and fundamental for us as evolution in the humankind, and fundamental for us in our daily life, I would say. Even now, as I'm talking to you, they are activated and they are working in both of us, I would say.
Yeah, and the brain is an amazing thing, right? And so much to learn and so much to pay attention to. So I follow your work. I have for a while now, and I know that you think that it's likely that young onset Parkinson's is significantly different than later onset Parkinson's. There's overlap, of course. There's some commonality, but I understand you to advocate for a broader understanding of Parkinson's to include young onset being in some ways a different disorder than what we see in later onset Parkinson's. Can you say more about that?
Absolutely. Yes, indeed. So let's use the term Parkinson disease, right? Parkinson disease is this condition described by James Parkinson almost 200 years ago, that identify a group of patients that had some specific characteristics that were common. Means they were slow, they have tremor, they have problems with moving fast and having falls. And they all share the same pathological background, which is basically a dysfunction in these cells that are inside the brain called basal ganglia. There are neurons inside this particular structure. And has been taught and has been taught to the student and to the resident, to myself, the Parkinson's disease is this uniform condition affecting anybody the same way when there's a damage in the cells. Well, the problem that we know now that these cells, these neurons, can be affected by different mechanisms, but the final outcome can be similar. So if my final outcome of the damage to the neurons is the same, but what started the process is different, the disease is not the same. The disease is completely different. And especially when we differentiate within Parkinson's disease, the different subgroup, and within the different subgroup, we differentiate between young and old Parkinson's disease and late onset Parkinson's disease. The mechanism leading to a dysfunction in these dopamine-driven cells are totally different. Totally different. You're right, there's some overlap, absolutely, especially in certain age. But the first thing that differentiates the two diseases, young and late, is the lack of aging in the young. So aging process is something that happens every day. Me and you and everyone in the world, we are aging every minute, right? The moment that we were born. But clearly, a brain in the 70s and 80s is absolutely much more frail compared to somebody in his 40s, is a fact, because there's 30, 40, 50 more years of aging, of cellular damage, of cellular regeneration and resprouting that is not occurring in the 30s and in the 40s and in the 50s, which is an important thing because number one, aging is not affecting young onset Parkinson. But let's forget about aging. What about mechanistic? What about the biology? Well, the biological mechanism leading to young onset Parkinson's disease seem to be also inherently different. We know that alpha-synuclein is the ubiquitous protein. So it's a protein that we all have anywhere in our body that accumulates, clog in the neurons and cause the Lewy bodies. The Lewy bodies are the hallmark of Parkinson's disease. In other words, if I look at open up the brain, I see the presence of Lewy bodies under the microscope. Well, the important thing is that these Lewy bodies are almost always present in patients that have late onset Parkinson's disease after the diagnosis, or sometimes even before the diagnosis. In young onset Parkinson's disease, we may not find them. So what does it mean? Clearly, the mechanism leading to the dysfunction of the neurons containing dopamine and causing different symptoms is not the same between young onset, late onset. Specifically, there's some evidence to support the mitochondria. Mitochondria are basically the little cells, the little organelles that are within the cells that are responsible for the oxygen exchange, well, the energy exchange in the cells. They seem to be much more prominent in young onset Parkinson's disease than late onset Parkinson's disease. And not only, there's also other differences to consider. Sometimes we are seeing metabolic diseases, so diseases that have different cause, accumulation of lysosome, accumulation of other form of protein that can lead later in life to something similar to Parkinson's disease, to the point that biologically we have to use Parkinson's disease as a name to differentiate and to give the right diagnosis, even for insurance or reimbursement purpose. But it wouldn't be maybe a wrong idea to not use Parkinson's disease at all in the young and consider a different name. Obviously, it's not possible to be doing that, but I'm doing an hyperbolic concept to try to make clear that we are dealing with two different diseases biologically, but also socially, physically. Symptoms are completely different sometimes. Symptoms are hardly recognized. There's a longer delay. We had to know exactly how long, but there are longer delay from diagnosis, from symptom onset to diagnosis in the younger onset to late onset. There's different needs. There are different implication in life, and there's different prognosis. Overall, the life expectancy of somebody with Parkinson's disease in the late onset from diagnosis, the median time is 12 years. So if somebody is in her started a diagnosis around 73, 74, we're expecting 12, 13 years before people are dying. Well, in young onset, it's about 48 years. So clearly we're talking about something completely different and not well studied, not well characterized. And even within young onset, there's so many differences that need to be understood, because what I have is not what you have. What I have is not the way I respond to the medication, the way I respond to the disease is different than what you do. We are living in a time where COVID-19, the pandemic, has shown massive differences between people. When somebody's getting the disease, somebody's not. Somebody's affected, somebody's not. This is the same in all the diseases, and is very reductionistic and quite superficial to try to lump everything together, because this is not what medicine in 2022 should be. We should customize, individualize, identify single protein or single markers that can guide us in different customized treatment for each single individual. That's what we are trying to do, but we are yet in the early phase of this process, but we have to move in that direction.
Yeah, it's fascinating. And one of the things I really appreciate about what you're doing is that it gives a theoretical and a biological basis for what a lot of people experience, namely, my Parkinson's is not your Parkinson's, is not her Parkinson's, right? I mean, you said it yourself, and there's overlap and some commonality, but we often say if you know one person with Parkinson's, you know one person, because we're all, at least slightly different. So I really appreciate hearing more about the theoretical underpinnings of why that, may very well be the case. So how do you treat young onset Parkinson's as opposed to later onset Parkinson's? Given what you've said, are the treatment protocols different?
They can differ. They can differ also substantially. Number one, we have to consider that late onset Parkinson, our gold standard for treatment of Parkinson's disease is still carbidopa-levodopa. So the best medication ever that we have so far, ever since the late 60s, has been marketed, is the medication that every new drug needs to be compared to, providing in late onset Parkinson or in Parkinson, generally speaking, 50 to 70% of improvement. So a medication that has some implication. You know, also the biggest fear of this medication is that after a number of years, and it is variable, we're going to tell you some percentage lately, people may have some fluctuations with dyskinesia, normal movements, or off, be frozen. But we have other, but even that is something in late onset is not the same. Only 39% of patients are developing dyskinesia, which means that the vast majority doesn't. So it's an important thing to consider. The bad name of levodopa was given through the 90s and early 2000s because there was some wrong evidence that has been proven to be wrong, that this medication could cause, could accelerate the process. Right. But you're right, it's not the case. There's a beautiful study coming from Europe comparing Italian patients and African patients when there is a delay in starting the medication, showing basically that Italian patients and African patients that have a delay in starting the medication are having the same frequency and the same time to dyskinesia. So this means that levodopa doesn't induce dyskinesia, is the disease that progresses causing dyskinesia. Right. But so levodopa is still the mainstay treatment, but in young onset, we have to consider something different. In young onset, we cannot say, okay, take whatever dose, 2 tablets 3 times per day, 1 hour before meals, as we're supposed to be doing, and see how you're doing. No, because the requirements of people that have young onset Parkinson disease are totally different. Let's say you're working out, let's say you're running a marathon, you need a different kind of treatment tailored for your requirement. Let's say you're a CEO of a company, you have to talk in front of your entire board and you'll be stressed and you have to work hard for that. You may need more medication. Let's say you're not stressed. Let's say you're on vacation and you don't need too much. We can give you less medication. Right. And most of this medication needs to be supplemented with other treatment that sometimes we can consider according to what we know so far, which is limited, but what we start to understand in terms of the individual biological and molecular mechanism of the patient. I give an example. If we identify in somebody with young onset Parkinson, mutations, genetic mutations, or molecular characteristics, biochemical characteristics that give us the hint that we are dealing with a different disease, we may need to work in a different way. We may need to give supplements, we may need to give sometimes monoclonal antibody, enzyme replacements. We should work in a completely different way than we do with the usual take 2-3 pills and see what happens. Yeah. Also, another important point, should I treat the patient? Depends on you. The amount of treatment, the amount of medication, the amount of medicine, and the amount of any sort of consideration in terms of treatment needs to be individual, tailored, case by case. And even I have patients that I say to them, just take 1 tablet of carbidopa, levodopa. You're good. You don't need to go more in this moment. Or some people say, okay, you cannot tolerate or you do not respond on carbidopa, levodopa because it happens in young onset Parkinson. You may use different medication, dopamine agonist, or I say, you know, we have to find a different way to deliver the drug to your brain, maybe with inhaler or having a controlled release or a combination, because another problem that we encounter in young onset Parkinson is that it's not sometimes that easy. We recognize a dopaminergic loss, but replenish the dopaminergic loss is not exactly as easy as in late onset Parkinson. Why? Because it's not the same disease. Because we had to find that because we have other biochemical problems that are playing a role and make us less likely to be successful at times in doing the replenishment as we are supposed to be doing.
Yeah. Yeah, that's really helpful. I know you touched on this, but just one more follow up. I know a lot of folks who have young onset Parkinson's in particular worry a lot about dyskinesia.
Mhm.
And some of them are told by their movement disorder specialist or their neurologist, let's delay introducing carbidopa levodopa as long as we can, because once you're kind of on the clock, you're on the clock, and you're going to be, 5 to 7 years on average, as I understand it, you're going to be experiencing, or there's a higher chance that you'll be experiencing motor fluctuations and dyskinesia. And so people are scared to take it, right? And that can impact their quality of life. So say more about that in your experience.
Sure. So is a little bit so the entirety of dyskinesia is a very important conversation, because it's usually the conversation that we have all the time with our patients, because is one of the most fear and most embarrassing sometimes to the patient, report to the patient, but no, Dr. Cole, not necessarily to the patient. Most of the time, it's the spouse that is embarrassed. Why?
Mm,
Because our patient prefer to move than be frozen.
right.
So typically, and we were saying we had to push the medication almost to the level of dyskinesia, because it means the medication is working. And by the way, the presence of dyskinesia is telling me that the medication is still working. It's too much, but it's still working. So it's not all negative.
Right.
The absence of dyskinesia completely sometimes made me question the diagnosis, because it's an important thing to consider that. Now, in young onset Parkinson disease, dyskinesia is present only in about 45% of the patients. 45%, not every patient, 45% of the patient, which is an important consideration. So not everyone develops dyskinesia. It's a little bit higher than late onset. When I told you before, it's 39. Here is 45%. There are some form of Parkinson's disease affecting the young that are much more sensitive to develop dyskinesia, when even a sprinkle of levodopa can cause them to be having a lot of dyskinesia. But I will know right away. The moment that I give levodopa, even a tablet or 2 tablets, I will see dyskinesia happening. And those are genetic forms that have some other problems that we need to be knowing. But the entire risk of having dyskinesia is, again, 45% only, and it's something that we can manage most of the time. It's something we can manage with other things, including deeper stimulation, duopa, and other treatment. But honestly, also medication like amantadine can be used and so forth. But honestly, dyskinesia has been some sort of demonized, because people have seen massive amount of dyskinesia, entire body movement. But if the movement is minimal, DEXA movement is marginal, it's not affecting the quality of life. And on the contrary, it's a signal that the medication is working.
Yeah.
So I would never delay the start of carbidopa levodopa. The delay was initially given with the idea that carbidopa was toxic. And as I mentioned to you, the time to dyskinesia is the same even if you delay the medication. So if you need the medication, you wait 3, 4, 5 years, and your brain was deemed to have dyskinesia anyway after 7 years of disease, you will get it after 2 years. So it's not something that will delay the onset of dyskinesia. That was a misconception that is being unfortunately dragged by early studies, and that were done by some opinion leaders that have been instructing and teaching the entire neurologist world. Then another problem that is not trivial, but to me is actually an important problem. Sometimes dyskinesia is also exercise dependent. So in other words, if you use a lot your body, it's unlikely you have dyskinesia, because you're consuming more dopamine. If you're more sedentary, dyskinesia can occur a little bit more often. So this is another important thing to consider. Another thing that I would like to mention about dyskinesias is that, again, spouses, as I mentioned before, are quite bothered, or partner are quite bothered, but not so much the patient. And ultimately, there is no, I give an analogy, I always give this analogy because I like it a lot. If somebody has diabetes, right? You will use, people are using for a while oral agents like metformin or oral medication that are used to lower the glucose. There's a moment that people need insulin. And when it's time to need insulin, you need to take insulin. You need to take the right amount for you, only for you. Now we have the sensors on the arm tell you exactly what you need per day and so forth. It's the same in Parkinson's disease. If there's a moment that you need levodopa, it's because your symptoms are offended or you're bothered by that. We cannot push the dopamine agonist more and more. We can't. We simply have to go to levodopa. And levodopa is the insulin of Parkinson's disease. People need to be taken as much as they need. And you're right. If you take too much insulin, you may have problems. You have hypoglycemia. Here, if you have too much levodopa, you have dyskinesia. But again, it's something that can be adjusted. And has to do with the time and effort that the physician and the patient are wanting to put together to try to tweak the medication according to the need of the patient, especially in the young. I want to give you an example about the treatment. I have patients with young onset with very little symptoms, but they have Parkinson's disease. So they don't need sometimes medication, they need minimal medication. But maybe they need to, maybe they're getting married. And we all know that during the wedding, you're stressed. You can use whiskey, good. You can use wine, but you're stressed. And if you had tremor, the tremor will be worse. So for example, in a stressful situation like that, I tell my patient, take more medication or start the medication. So we can abate your symptoms just for that 2-3 weeks of your wedding time, and then you can stop. Or this is valid for any other initiative or any other event or life event that you had to do. But I am not fearful of dyskinesia, and we should not be fearful of dyskinesia. We should try to revise this concept as much as possible, because the fear of dyskinesia, and this fear has been, instillated, foraged by the scientific community, is making people delaying their treatment and having years of being suboptimal or not optimal at all, when, as we sometimes we say that, right? We can treat you now in what you need today. I don't know what happened tomorrow. I don't know if you're going to have a war. I don't know if, I don't know if heart attack will occur. I don't know if there's a car accident, and then this will limit the opportunity. But in the now, in today, I have to treat you. Is the most important thing that we have to do.
Yeah, I appreciate you saying this so much, because people do struggle with this question and they get mixed, information on this. But friends, if you're watching this and you're worried about dyskinesia, don't worry about that being brought on by taking what you need to take to have a higher quality of life as early as you can. There are ways to regulate it. I'm hearing the doctor say, and don't delay if you need it.
But
So you've talked. Go ahead.
No, I would say this is unfortunately something that is being brought on by years of literature that were going in this direction, but in reality, it's not necessarily the case. So you have to partner up with your doctor to try to find the best source for you. And there's some people that will have dyskinesia even quite severely, but there's, generally speaking, usually there's a way to control that.
Yeah, really important message. Thank you so much.
Absolutely.
That's one of the misconceptions about Parkinson's I wanted to ask you about, or one of the myths. Are there others that you think we should touch on that folks should hear about?
So the biggest misconception is that, as we talk, delaying carbidopa levodopa, right? We need to use the insulin when we need. We need to use levodopa when we need. When people are having symptoms that are interfering majorly with their life, rather than being miserable, it would be better to start to feel a little bit better and work proactively to do everything else: supplements, diet, exercise, being active, being fit, socially engaged, and taking the right medication. So it's very important that the biggest misconception that we have is levodopa. The other misconception that people are having is that sometimes people are saying, no, I'm going to use dopamine agonists instead, and they're going to be better. Well, I don't say are better or worse. They're less potent. I have patients that are doing great with this medication and poorly with levodopa. But why? I told you, everybody's different. And we need to be open and not rigid in changing opinion according to the single patient. But we know that they are also having some side effects that are quite severe. So we need to be very careful and be cognizant about some of the side effects, such as changing behavior, memory loss, these hallucinations. I know people are talking about gambling and shopping. Sometimes it's not that bad. Sometimes are intruding a hobby like fishing, and every pond you see you have to fish. Is not a bad thing. It's not causing you any trouble, but it's intruding your day. So the misconception of the drug is the most important thing. Another misconception I want to mention is that I have Parkinson's disease, I'm going to be on a wheelchair. No. You have Parkinson's disease. It's not good. It's never good to have a disease, whatever disease you have. But the outcome is not being on a wheelchair with dementia, with memory loss, with being seeing things and having hallucinations and be confused and not be able to function. No, everybody's different. So that outcome can occur, but especially if you're young, especially if you're proactive, especially if you don't have additional comorbidities, that is not your outcome. And we have to think, and this is what I say to my patient, do not think that as your outcome. It can be, because any disease, even the most simple mole can be a melanoma, you can die. But we are talking about frequency statistics here, and it's not the outcome of the patient. So the equation, Parkinson's disease equal to life of misery and death, is not really a strong one, doesn't hold water, not in these days. Okay, this is another important myth that need to be considered and removed. Another thing that is important, I have Parkinson's disease, I am young, this is a genetic condition, is inherited, I'm gonna pass to my kids. No. There are some forms that in this moment are the minority, a slim amount of patients that have strong genetic background, familiar background that goes into the family, and people are inheriting that. But the vast majority of people with Parkinson's disease, and the vast majority of people with young-onset Parkinson's disease do not have any family history and do not have any gene that we know of, any gene mutation that we know of. This is telling us something, that clearly the disease is a combination of genetic factors, environment, and other things that we do not understand. But the lifetime risk in the population of having Parkinson's disease at any age is about 1 to 2%. If somebody has somebody in the family with Parkinson's disease, the risk doubles, goes through 3% more or less. The lifetime risk of having cardiovascular disease and dementia is 15 to 20%. So it's still a small risk. In fact, people are dying of what? Cancer, stroke, cardiovascular problems. Those are the things that cause people to die, not necessarily Parkinson's disease, not necessarily this condition. So it's a very important thing. Third myth that I think is relevant. My grandma or my grand-grandma had Parkinson's disease. She was in the mental hospital, especially in the 70s. That's what happened for a long time, and she wasn't able to move, and she was frozen. Yes, that was a different era. We didn't know how to treat the patient. That was a completely different era. And as you know very well, the moment that you had a condition, you were institutionalized for months, years, sometimes even more than that. So we had to be very careful to confuse the history of medicine and the memory of medicine that we have, and the memory of knowledge that we have affecting our family, with what would happen to us and what we know and how the situation has evolved. That's very important to consider. So those are, to me, very important myths that we need to debunk or at least discuss, because as I mentioned, what I told you maybe is not applying to the individual patient that has some more severe condition, some progressive disease faster, but I had to talk in a general term, but the effort is to individualize the treatment, customize the treatment. That's an important thing.
Yeah, it's not a one size fits all by any stretch, right? It's very,
No,
very tailored to the specific patient.
absolutely.
As you were talking, I just recalled two things that the neurologist who diagnosed me told me when I received that diagnosis. He said, um, one thing he said was, something else is going to get you, right? Meaning it's not going to be Parkinson's. It's going to be, what you said, cancer, heart disease, something that gets most of us, not going to be Parkinson's. And the other thing he said was, don't let somebody else's story be your story, which is what you're saying as well, that it's, just because you see a sort of a caricature of Parkinson's, which it often is, I think, a caricature sort of in the broader culture, which is what you're describing is a not the majority of cases. But remember that we all have different stories, and we don't have to assume that somebody else's story is going to be our story.
But we have all different lives. I mean, clearly, and many researchers are reporting that, even someone think that we did, your exposure throughout your upbringing, that is not just social upbringing, like personal upbringing, the way you grew, the where you grew, what you were exposed to, what medication, what food you've been exposed to all your life, what air, what oxygen you breathe, what water, what the soil that was used to grow the veggies, and the ketchup that was given to you by your mom when you were 4. All these are piling up. And
Right.
all these this is environment at its best. The time you spend in school, the time you've been fighting with your friends, the time you've been getting out with your girlfriend or boyfriend, all this is piling up together and is making us who we are. And is making us the brain that we have, because the brain is where we live. This is where things are happening. And the way things have been developed are so different one to each other that there have been beautiful studies on twins, identical twins, so allegedly with a same genetic background, they grew up in different places and they had different diseases.
Right.
Because they were exposed to completely different environmental factors. And again, even these are maybe misconceptions that we have to consider. I agree entirely with you, is that, having one risk factor, okay, I hit my head 5 times or 20 times. Is it bad for me? For sure, it's not good for you, but it's not sometimes a discrete event.
Yeah.
Sometimes are an accumulation of little things that you accumulate your entire life, 20, 30 years. But then there's also protective factors that we have very little knowledge about that can eliminate, annihilate, and reduce the risk of having one condition or another. Likewise, genetic risk factors or genetic protective factors that are interfering together. I like analogies because it's the best way to visualize the problem. We talk about Parkinson is easier, young or old. What we are able to do now, we are able to have some knowledge of the club, the bat that is going to hit us. Genetic and risk factors say, okay, this is the size of the club that is going to hit you. The size of the bat is going to hit you, or maybe has already hit you. But what I have no idea, knowledge about yet, is what kind of helmet are you wearing? Zero knowledge.
Yeah.
It can be a leather helmet, it can be no helmet, it can be an armor helmet, no idea.
Yeah.
That is the most difficult challenge that we have to deal with, because that has to do on how we react to a disease, whether it's Parkinson or something different.
Yeah, I love that analogy. I think it works perfectly. Thank you. A couple more questions for
Yes.
you, Dr. Savica. What gives you hope as you look ahead? What does the landscape look like in the future with respect to current research being done? Where's the smart money on better treatments and maybe even a cure someday?
Well, I tell you, what gives me hope is that I've seen in my lifetime, in my career actually, incredible improvement in technology and in treatments. Not too much in terms of medication because it's not changed too much. But to give you an example, deep brain simulation, I've seen amazing improvement, an amazing development of new technology, microstructural changes, small batteries, a remote ability to control from distance, and so forth. So clearly, we are going fast with technology. My hope and what gives me hope is that we are likely, and that's the important thing, we are likely on the verge of some revolution of thinking about Parkinson's disease. And we are already thinking that many colleagues around the globe are marrying these ideas that we are dealing with a number of diseases that have the same outcome. And I think, if you tell me, do you think that we will cure completely Parkinson's disease? I say it's unlikely, because we are dealing with a condition that, as I told you before, affects the old, and aging is something that, aging of the cells is something that happens with every cells, including the cells of the brain. And I don't think we can defeat aging, which is something that makes us human and makes the circle of life. But what we will be able to do, I think we can change the way some patients with some specific individual biochemical, metabolic, and genetic characteristic have on how they respond to the medication, how they respond to the disease.
Right.
So do you think that do we think that we will be able to identify an agent that can delay the progression of Parkinson's disease into anybody? No. But I think we will be able to find more than one agent, more than one medication or treatment that will improve different kind of patient with some specific characteristic, and that can make the disease delayed quite substantially. And is occurring already to some extent when we identify metabolic changes that have already a treatment. So we can start the treatment already. So this gives me hope, because I think that where we are heading and what we are seeing, I truly hope that there will be more resources for young onset Parkinson's disease and for research devoted specifically to young onset Parkinson's disease. This is something that is not necessarily occurring. Also because, and this is not a criticism, but usually it's easier to fund mainstream research. It's more difficult to fund research that is high risk and high high risk. In other words, if you fail great. Right. And there's a risk to fail that is higher, whereas sometimes funding agencies are more going to the mainstream one. These slow things down. So I think there's different ways to try to support the research in a faster way if we can, I would say.
Yeah, I really appreciate that last point in particular. I work in a university, as you know, and it's clear that with respect to funding for medical research in particular, that the fewer people comparatively who are affected, the more difficult sometimes it is to get funding. So in Parkinson's, those of us with young onset are a much smaller group than folks with later onset, although our group is growing, as you know, statistically very, very quickly. But to your point, it's sometimes harder to get the attention of funders because it's a comparatively smaller group.
Yeah, it's a smaller group, and and it's interesting. Clearly, it's growing. Young onset Parkinson, all Parkinson is growing, but young onset Parkinson is growing as well. And I think it's yet to understood why. But I give you an example, right, about science and how science works. Unfortunately, everybody now is using omeprazole, pantoprazole, pump inhibitors against ulcer, against acid, anti-acid, right? drugs that are made, that we all use, right? It's not difficult to be having access to. Well, the person that won the Nobel Award of Medicine that discovered that ulcers were actually infection. So you had to use antibiotics to kill the Helicobacter pylori. There's this beautiful footage online when he presented his data, and he was booed, left. People were making fun of him because he was so revolutionary that nobody understood. And in fact, this guy ended up publishing his first research in a good journal, but not a mainstream huge journal, for example, from the East Coast. This is telling, but then this guy changed medicine completely, changed completely medicine, saved thousands of people's lives. And this is telling us exactly that sometimes having the attention of mainstream science is not easy. But mainstream doesn't mean that we have to think alternative things. No, we have to have a scientific ideas, doing good science with scientific background, with reproducibility, using the Aristotelic, if not Galileic way of doing things. But it's not easy. It's not easy to have ideas that are sometimes affecting a group of people. As you say, it's not that big, and however, it's bigger, and it's difficult to get the attention that is important to have, I would say.
Yeah, I agree with you 100%. So one final question, and I could talk to you all day, but one final question for now, and maybe we'll do this again sometime soon.
Sure.
You diagnose a lot of people with young onset Parkinson's, later onset Parkinson's. Mayo is a destination, treatment center for a lot of people. So you have a lot of experience. What's one thing that you would say today to those who are newly diagnosed that you think it would benefit them to hear? If you could tell them one thing, what would you say?
The one thing is to be proactive. Be proactive means in many different ways. Means taking the medication, work with your neurologist, reach out to your physician. And if you don't like your physician, and Dr. Cole, there are people that don't like me. I know that. Go somewhere else. It's fine. Or people that go exercise, go work out, have a good life. Try the best to do something fun and pleasurable every day. Workout is crucial, so be proactive and work out, do something you like, something you need to be doing. Work with your mind, making sure that you're not gonna fall. You have a strategy to avoid falling or to avoid to work with your limitations if you have any. But also have a good diet, have a nice pleasurable dinner or lunch or what you prefer. Try to incorporate good moments in your life every single time. And do not think that having a diagnosis of Parkinson's disease is the end of your life. That's the most important thing that we need to say. It's better not to have any disease, not only Parkinson, any. But if you're proactive, if you're connecting with other people, if you're networking, if you're having a fulfillful experience in your life, that's what we need to be doing. And I tell you this, those are not vacuum words, they're not empty words. Those are words given to the fact that the people, the patients that are the ones that are doing good, the ones that have good prognosis, the ones that are not progressing as fast, are the ones that are doing all this, that are investing themselves in their own development, in their own, in ways to try to defeat the disease. And on the other hand, do not fall online. There's so many information, too many information. What I don't like, I really don't like my patients to waste their time and money, especially money, in things that are very expensive, that maybe do not have great, great scientific background. That's what I would say. But on the other hand, do everything you can to really be proactive and to live in the present. Future, we don't know what happened to any of us. but
Yeah.
in the present. That's super important.
Well, I really appreciate everything you've said today, and particularly what you said at the end here. I think, being proactive and living in the moment are great things for everybody to do, but particularly those of us who are living with a chronic illness. And Dr. Savica, I can't thank you enough for being here today, for the work you do and how you do it. It's really an honor to have you on PD Wise, and we'll have you back, I hope.
It's been a real privilege, and as you know, I'm more than happy to, through PDWise, but through your work as well, to reach out more people. And we are more than happy to be in touch with everyone. Me and my team here, we are trying our best to at least impact the life of, even, always tell you this, if I'm able to improve 5%, to cure 5% of people in my life, cure with Parkinson's disease, I will be satisfied.
Yeah, well, it's very encouraging. We need more physicians like you, and thank you for being here, and thank you for what you do.
Pleasure. Want to see you later.
Bye-bye.
Bye-bye.